recording this presentation just so that we can, kind of put it on our YouTube page so that, anyone who wants to revisit it at a later time can do so. Okay. So here are my disclosures. So basically, the 5 objectives of the webinar today are: number 1, to discuss standard approaches to IIH stenting. Both Dr. Ramos and I will be showing our standard approaches, and they are a little bit different, so it's good to see how things are done differently. Number 2, we go over management of cases where passing the stenosis is difficult and discussing the possible role of angioplasty. Number 3 is Juxta-stent stenosis, how and when to treat. Number 4 would be discussing in-stent stenosis or thrombosis in patients who also get recurrent IIH, and what's the management in those situations. And I have a tough case of that to show. And then number 5 will be discussing bilateral stenting, which is very rare, but does occasionally come up. So, Stylianos, do you want to go first and discuss your standard approach to IIH stenting, or should I?
Whichever way you want.
Okay, I guess I'll go, and then you can go after.
Yeah.
So first, when we talk about the approach, one of the key things we have to discuss are, the strategy. And I think one of the most important things about the strategy in IIH is number 1, making sure that you have a good team, which includes a neurologist and a neuro-ophthalmologist. And number 2, trying to be strict in your diagnostic criteria for who you're treating, because that way you can, you're very consistent, and you know what the outcomes are going to be. You can predict the outcomes for your patients. So the criteria that we use for diagnosing people in IIH and considering them for stenting are these criteria that were published by Friedman in Neurology in 2013, and it includes the presence of papilledema, normal neurological exam except for maybe an abducens palsy, normal brain parenchyma on MRI, normal CSF composition, and elevated opening pressure. Very rarely we'd come across patients who don't have papilledema, but have imaging findings of IIH in addition to elevated opening pressure and some symptoms like tinnitus and headache. For stenting, who are the patients that we select for stenting? Essentially, it's patients that have an extended period of maximum medical therapy and weight loss with no or minimal improvement. And weight loss is probably the most effective treatment for IIH, but is the hardest thing for patients to accomplish. Moderate to severe papilledema, and we used to not treat patients with vision-threatening disease. Sometimes those patients with the grade 4 or 4+ papilledema would go directly to shunting, but more recently we have been treating patients with grade 3 or 4 papilledema as well. Another indication would be intolerance of acetazolamide. And I'm not just talking about, kind of numbness or funny sensation in the lips, but, some patients, they just cannot function while on the drug. They have fatigue or brain fog. They can get renal stones or other complications of the medication. We give all of our patients aspirin and Plavix. We load them for about 5 days beforehand. And we continue dual antiplatelet therapy for 3 months if a stent is placed. And then after that, just aspirin monotherapy. Contraindication would be a patient that would have a need for any type of surgery 3 months following stenting just because of the dual antiplatelet therapy. We do all of our cases under local anesthesia with IV sedation. During our pressure measurement phase, it's just kind of some Versed and fentanyl. But prior to stenting, like immediately prior to stenting, we ask our anesthesiologist to administer a propofol bolus because that part can be pretty painful. So what's our technical setup? transfemoral access, ultrasound. We use a 6 French Neuron Max or ballast. We insert it primarily, no short sheath. Then we use a 5 French Sophia, 125 centimeter for the pressure measurements, and advance that over an exchange length transcend. And we get pressure measurements throughout the whole venous sinus system if we can, from the left IJ through the torcula and then to the right IJ. And our decision to stent is based off the presence of an angiographic stenosis with a gradient of 8 to 10 millimeters of mercury or more across the stenosis. Typically, we use a long carotid wall stent. And then the past 3 cases at Stylianos's recommendation, we've started to try out the Zilver. And then we measure a post-stent gradient. And then we discharge patients same day of the procedure. This is some important thing to discuss. Something that happens often in these patients is they get localized pain at the site of the stent and some ipsilateral headache for the first couple weeks after stent placement. We do treat that with a little bit of oxycodone, occasionally some steroids. If patients have grade 2 papilledema or better, we do stop the Diamox. But if they have grade 3 or 4, we continue the Diamox until the improvement in papilledema has been documented, typically around 3 months. And then we do a CT venogram at 3 months. And if there's no issues, we DC the clopidogrel, and they are on aspirin 81 milligrams for life. So let me see here. I can just show you a standard case where we use the wall stent, how we do our pressure measurements. We try to go across the stenosis with the guide wire in a J configuration. Sometimes it is actually very difficult to get across the stenosis. So these things can be pretty tight. And then because we have an exchange length wire, we're able to get it all the way to the contralateral internal jugular vein, and then essentially advance our Sophia into the internal jugular vein. We're able to get our Neuron Max typically, in the sigmoid or distal sigmoid sinus. We go ahead and do our pressure measurements at various stations, and then do our venograms. And then after that, if we do see the stenosis, we basically try to advance the Neuron Max as far as possible across the stenosis using the Sophia as kind of the guide. Sometimes using a buddy wire like a 35 glide wire is helpful. And then after that, we, getting the Neuron Max as far as possible, we go ahead and deploy the stent. And you can see that this is somewhat painful for the patients, but the pain, it goes away pretty fast. And with the propofol sedation, nobody remembers anything. And this just shows the stent deployment post, the pressure measurements and everything. So that's kind of how we are typically doing our standard cases. Now I'll have Stylianos go ahead and share his experience with management of standard cases. Then we can take some questions before moving on to the next topic.
So my overall experience with this condition has started approximately in January of 2016. Ever since, I have treated a total of 75 patients. We have a fairly obese population, and this subset of patients usually have a fairly high body mass index. Our mean pre-BMI is 42.5, consistent with morbid obesity numbers. These are just some numbers of our cases. 75 patients, our mean pressure gradient has been close to 20 millimeters of mercury, with a pressure in the size of sinus at 32, sigmoid sinus close to 11. And similarly, I have not had to convert any one of these stented patients to ventriculoperitoneal or other shunting. Our indications are similar: the presence of papilledema with or without a known increased opening pressure on a lumbar puncture in a patient with a fairly normal MRI brain with contrast, excluding all the findings that we commonly see in intracranial hypertension. I obtained a preoperative MR venogram with contrast to assess the side of the dominant sinus and to assess the anatomy of torcula in case access may be tricky. Pharmacological management is very similar. I use dual antiplatelet therapy, either aspirin and Plavix, which I start approximately 1 week before the procedure, or if the case is more urgent, I use aspirin and Brilinta and then convert to Plavix, or Eliquis for 3 months if there is an underlying thrombophilic disorder. And then the antiplatelet aspirin, I keep it on for the next 3 months and then stop. During the procedure, I use heparin. I do not reverse it. And I also use a moderate sedation only, either with the interventional radiology nurse or CRNA. I use fentanyl and midazolam, and I commonly bolus once I introduce the exchange wire, as I'll show later, with a hefty dose to make sure that it is not painful. I have had so far a patient who has done very well. Her papilledema resolved. She has no headaches. But when I called her to bring her for her follow-up venogram, she refused to come because she's experiencing a post-traumatic stress disorder after the stenting. So, yes, it can be painful, and but I think that general anesthesia adds a confounding variable, and I therefore avoid it. Imaging follow-up, I bring the patients for a transfemoral venogram at 2 years, and I wanted to do that because there was such positive data, and I wanted to see how those gradients behave in a long-term fashion, obviously with the target of publication in the future. I have had 32 patients we have followed up with a 2-year venogram, and our mean pressure gradient has been fairly low, 3.2, and the mean pressure in the sagittal sinus 13 and close to 10 in the sigmoid sinus. The patients who conclude this follow-up are then followed with an MR venogram at 5 years, and I'm planning to do this every 5 years. I have had the luck to work with one neuro-ophthalmologist who sees the bulk of these patients before and after the surgery, and another group that has 3 neuro-ophthalmologists who also see the patients before and after. And we request that the same neuro-ophthalmologist sees a patient, each separate patient. So we do a pre-op evaluation, then a 3-month post-op evaluation. I see them at clinic as well at that time, and then an annual post-op neuro-ophthalmological evaluation. I have done a CT venogram in patients who have complained of symptoms that seem to be a little bit more than the average post-operative pain. But other than that, I reserve that depending on the findings on a neuro-ophthalmological exam. This is a case presentation of a more standard case using standard access and an ipsilateral approach, which I have used in the overwhelming majority of cases, almost 95% of cases. This is a 20-year-old woman who presented after having a 3-week history of headache and visual difficulties. She had visited a few emergency rooms in the meantime, and she also has a history of OCP use for polycystic ovarian syndrome. When she came to the ER in Little Rock, she was found by my fellow neurologist to have severe papilledema and profound visual acuity loss with she was able to count fingers only on one eye, and she was able to perceive light only on the other. So I loaded her with Brilinta and aspirin and transferred her to our facility at North, where is our dedicated neuroscience institute, and proceeded with urgent/emergent intervention. We got an MRV prior to her arrival to make sure that she did not have any acute occlusion. She did not. She had the dominant left transverse sinus with marked venous outflow resistance on the left side. My standard approach, and out of need and necessity, I have tried to use the cheapest possible configuration. We did some trials on the first cases to see what the most successful recipe would be. And we have found that just using a transfemoral access with an 8 French sheath and using a triaxial system with just a plain glide wire 0.038 and a 4 French 120 centimeter glide cath as the intermediate catheter, we can thread the neuron max over that system in almost all cases into the distal sigmoid sinus. I use a 4 French 120 centimeter glide cath in almost all cases where interventional cases to advance and position my guide catheter. So I'm fairly familiar with its use. And for this particular scenario, I think it serves pretty well given its shape and the anatomy of the transverse sigmoid junction. So we do a venogram and then we measure the pressures. And in this case, you can see the venous outflow resistance on the left side on AP and lateral views. I use a Renegade high flow because it's cheap. I've never had to use a Marksman or a Phenom or more expensive microcatheters, and either an Avigo 14 or a Headliner 16 wire. And in this particular case, it was the most dramatic pressure that I have seen. If you see here, that's here vital signs at the same time. We had to zero our transducer multiple times to confirm that her pressure was indeed close to 100. So she had a pressure in the sagittal sinus 98 and in the sigmoid sinus 6 for a pressure gradient of 92. I transduced the pressures through the 27 microcatheter for the sake of uniformity ever since we decided to use the same configuration. And I pull it back and I measured then in the sigmoid sinus, and depending on the dominance of the sinuses, I will measure on the other side as well. In most cases, when there is clearly a dominant side, I measure only on the dominant side. Just for the sake of clarity, if there is a strong suspicion that the patient has an underlying venous hypertension associated idiopathic intracranial hypertension based on MR venogram findings and the presence of papilledema, we do not do transarterial arteriography, and we prepare to do the stent in the same setting. So we do the manometry, venography, and the stenting if the manometric findings are also suggestive of the presence of this condition. So in most cases, we do this in one setting and without any further imaging. Now, when after all the measurements have been obtained, I then introduce an 18 exchange micro wire. I use an Asahi Treasure exchange wire. And then I advance in almost all cases. I have used a Silver 9x60. In some cases, I have used a Silver 8x60. This is a fairly easy to use stent that has been very reliable for this purpose. I did my first few cases. I used 40 millimeters in length. But I think that you can obtain better purchase, and you can also soften the angle of the transverse sigmoid junction by employing a longer stent. And in this particular case, it has been my pretty much the only stent I have used for this purpose. As you can see, there's a little bit of I try to deploy this once I anchor it proximally. I try to deploy it as fast as possible within reason, obviously, in order to exploit the pop-up effect of the stent and avoid having to do any post-stent angioplasty. In this case, as you can see, there is a little bit of a waste at the site of resistance. And in this particular case, I did not have to do an angioplasty. I was able to thread the 4 French glide cath over the wire. And in a similar case, like with pipeline flow diverters, just the introduction of the catheter was able to oppose a stent better against the wall. So this is post-completion venography and manometry. The pressure has dropped down from 98 to 14, and the pressure in the sigmoid sinus is 14 as well. And you can see the tracing. And she did well. Now, as for, there have been local patients that I feel fairly comfortable and I can trust them, and I have discharged them the same day. The prerequisite is that they spend at least 4 hours in PACU, and I do a post-completion CT head in the angio suite on all patients to make sure there is no hemorrhagic complication. There have been patients I have admitted in the ICU. There have been patients I've admitted in step down on the floor. Again, it depends on the amount of pain that they are experiencing after stenting. But in almost all cases, they have been discharged the following morning, and they remain on dual antiplatelet or anticoagulant therapy, as we discussed earlier. And then I follow them in clinic myself at 2 months and then yearly afterwards.
Great. So Dr. Lanzino, Dr. Cumpy, what comments do you have regarding the different setups, and you know, does anything kind of differ from what you're used to doing? What are your thoughts?
Giuseppe, you want to go?
No, go ahead, Dave.
Okay. Yeah, we've had a somewhat different approach, and I started stenting in 1999 for this, and so nobody knew much of anything about it at that time, and I was sort of learning as I went along. So a couple of things. We do arteriography, diagnostic arteriography. I wanted to get follow-up on those and see that the vena labae did stay patent. With the diagnostic arteriograms, we do change it slightly in that we use a steep down view that lays out the sinuses very well, and get obliques, particularly the anterior oblique on the side you're going to stent on the PA view, is very helpful for distinguishing intrinsic versus extrinsic stenosis, and I want to discuss that a little bit later. And then we use a larger amount of contrast, usually 12 to 13 cc's of full strength contrast. Give it at 3.5 to 4 cc's a second, so if anything, a little bit slower. You don't need to film fast, but you get a beautiful venous phase that way. Then we have only treated papilledema. We insist that they have papilledema and all the other stuff that you outlined. We have only used Zilver stents for the last 10 years, and I could go over book and verse why that is, but they track better than any of the other stents I've ever tried. And then also with sizing, you folks are using larger stents. When you look at the cross section of a stent, it's triangular. So when you measure the diameter on the PA and lateral views, you're looking at a triangle, not a circle, okay? And so if anything, we will do a stent no larger than the diameter, and often downsize 1 millimeter, because I did start out thinking, okay, let's just use 9 or 10 millimeter on everybody. They all had headaches. And that's because I think you're stretching the dura around the sinus. And so if you go down to a 6 or a 7, they, I think, have fewer headaches. So we have started using somewhat smaller stents and gauging it to the size of the sinus. Also, we stent the entire transverse. I'll show you reasons for that a little bit later. The entire transverse, but not up to the torcular, down past the stenosis into the sigmoid. And I'll show you reasons why that a little bit later. I want to have some comments on case 3 for sure. Okay, that's the points I wanted to make.
Thanks, Dave. I like to stress that, like as Dr. Campe stressed, the purpose today is to focus as much as we can on all the practical things. Of course, my approach is very similar to the one presented by Dr. Bringigi. I used to use the wall stent, but then after discussions with Dr. Camp and Dr. Ramos, I was convinced that to use the silver and a longer stent made definitely a lot of sense, and that has been something that we have changed over the past several months. We used to use a wall stent, and one of the issues with the wall stent is that you really had to place the stent very precise across the stenosis, and especially the proximal end tends to foreshorten quite a bit, and the behavior around the stenosis. Now, what I like to discuss, and I'm interested, Dr. Kemp, in your comments about this, is that I was very, very afraid before start doing this years ago about the issue of venous thrombosis. I said, well, let's, the venous flow, it's slower than the arterial flow. We're going to put a stent. And these patients often have some degree of a prothrombotic state, but I've been surprised by how uncommon is actually any delayed venous thrombosis in these patients. And a few months ago, talking to one of the peripheral radiologist, he told me is that in the periphery, they are actually realizing that you're placing a stent when you work on the venous side, you're placing a stent in a vein that is otherwise morphologically intact. It's not an atherosclerotic process. And they are being much less concerned about antiplatelet therapy. And the question for you, Dr. Campe, is that do we really need 3 months of dual antiplatelet therapy in these patients?
Well, I actually use 6 and then aspirin. And the reason is not for thrombosis at all. It's for any worry about intimal hyperplasia. Now, it's turning out that doesn't seem to happen very much at all. Thrombosis is almost a non-issue. I've had 2 instances of it in my whole experience, and one was a partially occlusive thrombosis at the end of it. It had been kind of a mess getting the stent in, and at the lower end of the stent in the sigmoid. And I just treated that with TPA overnight. So that was an acute thrombosis, non-occlusive. And it disappeared with 16 hours of TPA, and we just then sent her home, and she's been fine ever since. The only other one was a woman who did have a coagulopathy, and 5 years after the stent, one of my early ones, she got a thrombosis of the sigmoid below the stent, and I had to clean that up with TPA also, and she's out now 100 and some months with no problem. And incidentally, I have stopped doing systemic heparinization when we put these stents in. It's a quick process. And I use the Bill Bank thing from Georgetown of just using a rather rapid flushing of the catheters with high heparin flush, 6,000 per liter. And that has worked just fine. But thrombosis is just not much of an issue, nor is in-stent stenosis in my experience. We haven't seen it, period.
Yeah, and we'll discuss that later on. And there are just a couple questions from the audience before we move on to the next case. So there's one question about critiques using a smaller catheter for pressure measurements. But is the gradient going to be accurate if you use a smaller catheter than if you use a larger catheter? After kind of reviewing the literature with that, and there've been a few studies out there on measuring pressures with smaller versus larger catheters. I mean, the pressure measurement itself is a little different, but the gradient, from my understanding, doesn't really change in magnitude if you're using a smaller catheter versus a larger catheter. And then there was a question about IVUS.
One comment there, Willie.
Yeah.
I took a number of cases early on where I measured the pressure through the guiding catheter in the internal jugular. And then I tried either an 021 or an 027 microcatheter. And the 021 pressures were lower. The 027 were the same as the guiding catheter. And I did that a couple of times. I said, okay, that's enough. I can't really tell you about whether the gradient would be the same because I didn't bother to check that.
Okay.
I have, Walid, I have measured, again, when I started too, I did the same thing. I measured through the Neuron Max, I measured through the 027 and the 4 French as well. And the pressures were very similar and the gradient was essentially the same. Ever since I have been measuring the pressures from the Renegade High Flow, the 27 microcatheter.
All right. So now I'm going to go over cases of where passing the stenosis is difficult and discussing the potential role of angioplasty. So I would say that the standard setup that I described to you earlier, that probably doesn't work in 15 to 20% of cases. Either we can't get the Sophia across the lesion, so we have to use a 27 microcatheter like a rebar. Or difficulty getting the wall stent across the lesion without doing something like using a Navion or something across it or doing angioplasty. So our setup works in a vast majority of cases, but in about 15-20% of cases we've had to modify. And I think there are cases where the wall stent or even a Zilver can't easily be passed through a stenosis. And the options there from our experience have been pre-stent angioplasty, which we do not do routinely, like we talked about earlier, or using a smaller stent, like a 6 millimeter stent delivered through a guiding catheter, like a Navion, like a 072 Navion. And for those of you who don't know, but you can't get an 8 millimeter Zilver through a Navion. In the wall stent, the 6 millimeter wall stent, you can go through a Navion 072. But if you're going to use a larger wall stent that has a OD of 075, so that's why we typically use the Neuron Max or the ballast in those cases.
Well, just a minute.
Yeah.
You said you couldn't get an 8 millimeter Zilver through a 072 Navion? We do it all the time.
Yeah,
Oh,
yeah.
I'm saying the 9 millimeter Zilver.
No.
Well, those are 5 French systems, though, the 125s, and that'll go. It'll go through a 072 Navion.
Okay, all right. Well,
9x60 Silver will pass through a 72 Navion.
Okay, all right. I stand corrected. Well, the wall stent won't, and so some groups have talked about using a contralateral approach. Some people have done transjugular, which I think is reasonable, but we haven't really done that. Dr. Kumpy, have you done these transjugular or done a contralateral approach before?
When you get to the case 3, the Juxta-stent stenosis, the stenization stenosis, I have a whole group of slides I'd like to show.
Excellent.
And we'll go over that at that time. I have not, my partners have used a jugular approach. on
There
a
is one issue we can discuss is that it's becoming not uncommon that we are getting patients that have increased intracranial pressure. They have a sinus stenosis, but they lack the phenotypical characteristics of this traditional pseudotumor patients. And several of these patients most likely have had the prior sinus thrombosis. And our experience is that these are the cases where the sinus is recanalized, but there are microchannels through, and these are the cases where it can be very difficult to get across the stenosis. And this is the case also that I recall where we have had a perforation. So David, do you have any comment about this chronic, most likely post-prior sinus thrombosis cases, and any particular trick or anything we need to be extremely careful about?
Well, no, those are very tough. You're absolutely correct. It looks like the sinus is open post, after they've recanalized, but there are all those webs and everything, and they're just horrible to try to get through. We don't call those IIH. We say, okay, it's post thrombosis. I've stented one or two of those, and you just have to work your way through very carefully is all. But I don't have any particular tricks.
You were talking earlier about the intrinsic versus extrinsic stenosis. I think, just kind of going through our cases recently, I think it's been the cases where our standard setup kind of doesn't work is the cases where we have these intrinsic stenoses, where there's actually something pushing into the sinus that just makes navigation more difficult. And I think this is an example of that right here, where it looks like there's actually something inside the sinus causing that intrinsic stenosis. This is a case of where Giuseppe and Harry Clough were treating this patient, and it was a case where they're trying to get past the stenosis, with the Navion, and there's just something. It just was very recalcitrant. It was very difficult to get across the lesion. Like even with the wire, there was some struggling. They tried to pass the carotid wall stent across the lesion. And for those of you who, if you look at the tip of a wall stent, it doesn't taper as nicely as like the Zilver, which I think is part of the reason why it's so difficult to get the wall stent across in some cases. And you can see how there's just a kinking of the wire right here, suggesting that, when I see this, I know that means that I need to stop because the stent is not going to get through at all. So in this case, what they did is they did a pre-stent angioplasty, which we've only really done for cases where there's an intrinsic stenosis, because it doesn't make sense to do it when there's like an extrinsic stenosis, because you're not really pushing anything out of the way other than probably the overlying brain. But after doing the angioplasty, they were able to successfully deliver the stent. And it's kind of remarkable how easy the stent glided through after doing the angioplasty.
Well, I agree with the angioplasty, and all those patients who are atypical will have an intrinsic stenosis. The ones who are 50 years old and skinny. But the way you avoid that is you take the Navion and you put it through to the end of the upper end of where you're going to put the stent. So never extending the stent, the Zilver, outside of your conduit catheter in any part of when you're passing.
One sec, I gotta mute someone real quick. If you're not one of the speakers, it'd be good to just mute, and then if you have questions, just send them on the chat. But yeah, this is a case where we were, had a lot of difficulty getting through the lesion, and then eventually we just resorted. You can see here, we resorted to just taking the Navion and dropping the stent through the Navion, and it turned out very well. So that's kind of the other way that we've been dealing with these. It's good to know that Zilver goes through the Navian. I didn't
The
I
sixth.
didn't know that. So
Well, Lee, there is a question from Ali Sultan about how we deal with an arachnoid cyst, an arachnoid granulation, sorry, and Dave, whether or not you would have any reservation in putting a stent across an arachnoidal granulation.
None whatsoever.
yeah, and I think this case here, the first case, I mean, that looks like an arachnoid granulation to me. I mean, it's got that, you know, multiloculated appearance, kind of pushing into the sinus at the transverse sigmoid junction. So I think this case where you guys did the angioplasty was a arachnoid granulation. Stylianos, what do you want to share your slides, and we can talk a little bit about that? I'm going to stop sharing. Oh, and then there's a question about what balloons we use for angioplasty. You know, we just use the Sterling balloons, standard angioplasty balloons that we use in carotid stenting.
So I'll present two different scenarios that pertain to difficulties encountered when crossing a stenosis. So one, I will use a distal access catheter that I have had to use in a couple of cases out of 75 we have performed. This is a patient who is older, 52 years old, skinny, and a pilot. And she presented with a headache and visual difficulty. She has papilledema, decreased visual acuity, has been on Diamox. I do not discontinue the Diamox. I keep it on. She has had multiple high volume LPs to no avail. And we treat her with aspirin and Plavix before the procedure. We measure the gradient and the pressures in the sagittal and the sigmoid sinus. You can see it's 20 and 6 in the sigmoid for a gradient of 14. But despite the overall presence, and you think, oh, it's going to be fine and it's going to be fairly straightforward to cross it, I was not able to cross the Zilver. This is the first time I have encountered this where the Zilver stent, either an 8 or a 9/60, was not able to go through the exchange, an exchange 00.18 wire. So in this case, what I did was to advance the neuron max over a distal access catheter. In this case, I used a Navian 72. And again, similar setup with a Renegade high flow and the Asahi Treasure, and was able to introduce the neuron max distal to the stenosis so I can stent. For me, the prerequisite is that the neuron max is in the sigmoid sinus in order for the stenting to occur. If not, then I do not think that it can proceed safely. So in this particular case, 9/60 was placed. The pressure drops, 6 in the sagittal sinus, 4 in the sigmoid sinus on AP and lateral venography post-completion. She's doing fairly well. She has a little bit of a headache. And then the next morning, I found her in the ICU. She was having her breakfast, sitting on a chair. And I noticed that she had this downbeat nystagmus, and that when I tried to assist her to get off the bed and get back from her chair to the bed, she almost fell on me. So this is her preoperative MRI, and you can see the ventricular size is fairly small. And so this is the first and only so far hemorrhagic complication that I have encountered in 1 out of 75 patients. I did a CAT scan. She has pretty severe hydrocephalus, and you can see there is a small subdural hematoma, and I can only suspect that it occurred at the time of exchange and all these more vigorous manipulations trying to pass the 72 and an 88 system over the stenosis. I suspect the exchange wire perforated the contralateral left transverse sigmoid sinus and caused this bleeding. So I ended up putting an external ventricular drain on her. This is her CT angiogram that we obtained at that time. The stent is patent, and you can clearly see the subdural hematoma on the coronal CT angiogram. I placed an external ventricular drain, and I left it in place for the next 8 days. I held the plavix for that particular day. And then once I made sure that there was no subarachnoid or tract hematoma along the ventricular catheter, I restarted the plavix at 24 hours after the incident. So I left the drain in for 8 days, and I was eventually able to get it once the subdural spontaneously regressed. And this is here CT a few months later, where the pressure in the fourth ventricle has resolved and the subdural is gone away. She has done very well. I'm actually scheduled to see her for her 2-year catheter venogram in a few weeks from now, and she's able to resume her profession. Another scenario is difficulty establishing ipsilateral guide catheter access. And I have encountered this again in a couple of cases. In 2 cases, I was unable to pass the neural max into the sigmoid sinus, despite using intermediate distal access catheters like an Avian, 5 French or 6 French. And therefore, in patients, both patients actually had favorable anatomy, and I used a contralateral approach. So this young lady presents with chronic headache and papilledema, loaded with aspirin and Plavix. She has a dominant left transverse sinus with resistance in the venous outflow at the junction. So I was not able again to pass the neuron max on through an ipsilateral approach, use the contralateral approach. The pressure in the transverse sinus was 26, in the sigmoid 8. And then I used again the Treasure 18 micro wire exchange wire and the Renegade high flow, and then remove the microcatheter. And the Silver is such a beautiful stent for this purpose. It tracks really well across both junctions, easily placed across the left transverse sigmoid junction. And the pressure gradient has now been eliminated, with the pressure measuring 14 on sagittal, transverse, and sigmoid sinuses. So again, I have had a very favorable experience with Silver. Again, it has been only one instance where I was not able to pass it through a stenosis of the transverse sigmoid junction. And sometimes it can be a little bit tricky to get the neuron max into the sigmoid sinus. Sometimes it needs a little bit of jiggling. But there will be some cases where you cannot do it, and I think the option of using a contralateral approach is always there, assuming that it's a nice bifurcation of the sigmoid sinus. Sometimes it can be bifibed, and it can have a steep angle where it at the torcula, and that might not be a viable option. But it's worth knowing the anatomy well from a pre-op MR venogram, so you can know all the options that you may have down the road. Thank you.
One comment, if you again have the conduit catheter, usually we use the Navian, we've occasionally had to use a Sophia. But if you have that passed all the way to where the distal end of the stent's going to be, the upper end of the stent every time that we've done it, the 5 French Silver will go through the thing. We don't have any trouble getting through the stenosis once you're passing the thing entirely within the conduit catheter, and then pull the conduit catheter back and deploy the stent.
Yes, again, I have used this more naked approach with the exchange wire and no distal access catheter in the vast majority of cases. If there is any difficulty, which has been encountered in a couple of cases, I have used a Navion 72 to go through it and deploy the stent through that. Again, as you said, the distal to the proximal to the stenosis.
Mhm. One little thing I've also noticed, if you're coming from below, just doing a retrograde approach, and you can get the wire through, but the catheter doesn't want to go through one of these stenoses. Sometimes what'll work is if you pull the microcatheter back about, maybe a millimeter or so, and then put some forward tension on it. And so that there's some tension built up in the microcatheter, then just pull the wire back. And the microcatheter will spring forward a little bit. It's surprising how often it'll go through the stenosis. And that's a trick we try. But these other approaches, even the contralateral, is very good.
Dave, I would like to go back to what you said before about the size of the stent, because we have had, and as a matter of fact, it's my routine visit with the patient where I warn them, I say, look, for the first 2 or 3 weeks, you're going to have a new kind of headache. It's going to be on the same side where we put the stent. And before, I thought that it was most likely just related to somehow some degree of hyperemia, not so much to the distension. But now, after what you said, I start worrying how much it's actually related to the fact that we do distend the wall of the sinus because we do tend to oversize the stent. And as you were talking, I remember that the case where we've had the worst ipsilateral headache was a case where we actually went on and angioplasty the stent. So if you probably then you have not observed as much as we have these cases of postoperative ipsilateral pain for the first 2 or 3 weeks.
Well, we don't see it universally at all, but you certainly see it. I haven't gone back and looked at all of how much, once we started using smaller stents, how often they had a headache then versus using a 9 or a 10 millimeter stent. I have the impression it's less, but they either get a headache right over where you put the stent or over the
over the ipsilateral frontal.
It usually will last a week, sometimes 2, but it's not routine. I mean, we don't see it in every patient.
And the other thing I want to mention is that when we started doing pre and post pressure measurements contralaterally, but then we stopped because we found what you would expect, that after placement of a stent on one side, the other side, the gradient improves, which makes perfect sense. Most people use one dominant transverse sigmoid sinus. So that's something else that we start doing routinely, pressure measurements before and after on both sides, and then we stop doing the contralateral side. I think there was a question, Walid, about whether or not we or the panelists evaluate the flow through the labet after placement of the stent, and whether or not there is any worry that can get obstructed. Dave touched upon that when he mentioned that it actually does do an arterial angiogram. We don't check it because we work exclusively on the arterial side. And the idea is that the stents that we use have such a degree of metal coverage that flow through the labet doesn't seem to be altered. Don't know if the other panelists have any comment about that.
We've, on all of the arteriograms that we've done, and it's somewhere close to 40, I think, on follow-up of patients, we have not seen a single labet go down.
Yeah, no, we haven't had any cases of vein of Labet thrombosis in our cases. There was one article in AJNR a couple of years ago that suggested that there was like a mild slowing of Labet in some proportion of cases, but you know, but I mean, you know, the superficial venous system, you know, there are, you know, there's a balance and there are multiple, you know, routes of egress. So I don't know how much a little bit of slowing affects things. I think the Zilver has a little less metal coverage than the wall stent. I mean, just looking at it, I don't know the exact numbers though, but that might be something to consider. And then there was another question: are there any tips for differentiating intrinsic from extrinsic stenosis? I mean, I think it's a good question because, you know, a lot of times it's discussed in the literature, but nobody's actually, you know, the clear diagnostic tips are not there. I mean, I would, when I look at cases, you know, an intrinsic stenosis is usually more focal, whereas the extrinsic one, it's kind of like a lot more of a smooth and longer segment of stenosis. So the case where we did the balloon angioplasty was very focal. That's what I would think would be an intrinsic versus the standard case where it's a longer and smoother stenosis or extrinsic. But Dr. Cumpy, do you have any comments on that?
Well, I'm going to show a couple of examples of that, but the extrinsic part of it is best seen on a steep down anterior oblique, anterior ipsilateral oblique, the side you're going to put the stent on, that anterior oblique. And it is a smooth indentation right along sort of the superior and medial portion of the transverse sigmoid junction. And you're right, the other, the intrinsic stenoses, I mean, you can often feel them with a wire, there's something there. And you usually can see them. For that though, if you've done the contralateral carotid, it looks like there is a filling defect where the stenosis is, because that's inflow from Labé. That doesn't necessarily mean there's an intrinsic stenosis there. You have to have the ipsilateral carotid to see that, whether or not that filling defect is still there.
All right, so now we'll talk about the Juxta-stent stenosis, how and when to treat. So, you know, with Juxta-stent stenosis, with our standard setup, it occurred in close to, you know, a little less than 10% of cases. We were typically using like an 8mm carotid wall stent in a vast majority of the cases. And the mechanism is unclear. We think that it's usually due to like there's still some increase in the ICP, so you get extrinsic compression by the brain and the area just next to the stent. We think that thrombus is a very unlikely cause because we don't see it on our postoperative CT venograms. And we're typically treating these patients if there's a persistent papilledema and a significant gradient across that stenosis. Now, just a little note, there was an article in JNIS recently where one group compared the rates of Juxta-stent stenosis from when they were using like a 8 or 9mm stent to when they started using a 6mm stent, and they found that basically the rate was 10% when they're using 8 to 9mm stents, and then 0% when they started using the smaller stents, which is very interesting. I wonder, and I'm going to be curious to see what Dr. Cumpy's and Dr. Ramos's experiences is with this, but I wonder if it's probably just way less common.
Mayo Clinic is committed to creating a safe environment for our patients and staff. To ensure everyone's safety, we require that patients, visitors, and staff wear a face mask that properly covers both your nose and mouth.
All right, sounds good. So basically, you know, I think that with using the long Zilver, especially because you're covering the whole transverse and sigmoid sinus, it's probably going to be very, very low for rates of Juxta-stent stenosis. So I'll be curious to hear your experiences, and I know we will. We typically manage these patients by placing a second. We haven't placed a third stent, but we would if we needed to, I guess. But we place a second stent overlapping at the site of the restenosis. So here's a case that we had recently. You can see the stenosis right here in that right transverse sinus. They also had a big occipital sinus, and here we are past that first wall stent, and you can see the wall stent kind of barely covered where the stenosis was in the first place, which gets to Dr. Lanzino's point about how, the difficulty with the wall stent in anchoring it and getting precise positioning. So here, we were able to advance the Navient past the point of stenosis, and then essentially, over the 14 wire, place a 6 millimeter carotid wall stent within this stent, and basically relieve the patient of the gradient. In this case too, they kind of had like a high riding jugular bulb, which did complicate matters. I think sometimes it's harder to deliver stents and stiffer catheters if patients have a high riding or higher riding jugular bulb.
Yes.
So that's kind of that. We can have Dr. Ramos show his example, and Dr. Kumpy as well.
Yeah, I'll have some stuff. I think people may want to comment on that later on after I show my series of slides.
All right.
You want me to go forward, Walid, or?
Yeah, go for it. Go for it.
So in my series, I have encountered this in 3 cases.
Did you want to? Do you have slides you wanted to share? Or?
Yes. Can you not see? Sorry. I must have not shared the screen. Can you see it?
Yep. Now we can.
Okay. So in my series, I have encountered this in 3 cases where I have had to treat, again, similar indications, the presence of recurrent papilledema associated with a high pressure gradient. Now, I have encountered this angiographically where there is some stenosis proximal to the stent, but if there is no gradient and the patients are doing fine, they have no headache, no papilledema, I have not treated it. And when you do the follow-up at a longer interval, like now we have multiple patients with a 2-year follow-up, it becomes certainly more frequent. So this patient, she had a known history of intracranial hypertension for a couple of years. She was treated with Diamox and high volume LPs, had a papilledema. So I treated her in April of 2018, and she had had a high volume LP 3 days prior to this procedure. The pressure in the sagittal sinus 22, 20 in the transverse, 11 in the sigmoid. And you can see that she already has a little bit of a stenosis in the posterior third of the sagittal sinus towards the torcula. And with the presence of such a small gradient, obviously I did not think about doing anything at that time. So stented the stenosis at the junction. Again, as Dr. Kumpy, I tried to put at least 3/5 of the 9x60 Zilver in the transverse sinus, trying to be away from the torcula, but certainly cover the almost all the length of the transverse sinus, and as short the 2/5 of the stent line to the sigmoid sinus. So this gradient was eliminated, and then she, at her 2-month follow-up with neuro-ophthalmology, her papilledema had resolved, only for it to recur. Only, so that was April, so like 8 months later, her papilledema has recurred. And now the pressure has shot up to 56, and you can see clearly now this proximal to the stent stenosis and the persistence of this stenosis in the posterior third of the sagittal sinus. So you can see on oblique views to see the stenosis better. And in this case, it was important to advance the neuron max as farther up as possible. Again, exchange 18 wire, and I have put a new Zilver 9x60 in the posterior third of the sagittal sinus, extending in a telescoping fashion in the indwelling stent. There was a little bit of a waste. Again, this is one of the few times I have done an angioplasty post-stent. I used an aviator. Somebody mentioned earlier in the chat what balloons to use. I have used once an aviator for this, and I undersized it significantly. I just wanted this to open a little bit better, as you can see in the final result. And I have used once a Sabre balloon to open a significant waste in another case. But the truth is there are no appropriate balloons, and you have to use whatever is available in the IR suite. So in this case, the gradient, again, resolved, and it was 17 in the sagittal sinus, 14 in the transverse and torcular region, and 14 in the sigmoid. So she came in for her 2-year follow-up. Still has no papilledema, but you can still see that the gradient is trying to get up again, and it's now 23 versus 14. This stented segment looks fine, but there is this area now that makes me worry, and she's one that I will be performing another catheter venogram next year, if especially if there is any recurrence of papilledema. But she's certainly somebody that I need to be checking more frequently. This is in oblique views.
I'll have some comments on that a little bit later also.
And why don't you go ahead and share your screen?
Well, no, it'd be better when I have all my slides up, Waleed.
All right.
Let's wait till we have all my slides, because I actually cover all these issues.
All right. Do you want to talk at the end, or at this part?
Either way, I do cover all of these issues. It might be better to go ahead and then afterwards go back to this case.
Yeah. Why don't we do that? I'm gonna stop sharing, and now you can share.
How do I? So, see, I'll bring up my. Just a minute.
There we go.
Got it?
Yep.
Ah, okay. A lot of days you're glad you don't have to take an IQ test. Okay. There are 3 types of narrowings. Intrinsic and intrinsic plus extrinsic just means that the pressure is high enough, it's also compressing. And then extrinsic, which is pure compression. This is the extrinsic compression, and you see that scalloped indentation that I was saying on the anterior oblique. These are intrinsics, pretty obvious. This is a combination where you see the extrinsic, but also there's an intrinsic. And we found when we looked at the patients that we had at the time, there's a pretty marked difference. Males are almost purely extrinsic, or intrinsic rather. Only one purely extrinsic, whereas almost half of females are extrinsic, purely extrinsic. Furthermore, when we looked at what happened later when there were the hemodynamic successes, in other words, no failure, or was there a failure where there was a recurrent gradient and recurrent papilledema, it was only females that failed. And when we looked at the interval to failure with one outlier that we probably didn't fix to begin with here, all of the failures happened at greater than 6 months. With the Juxta-stent stenoses, it was out to 24 months. We didn't see any beyond that. And with the extrinsic plus intrinsic, these were all technical errors on my part. And I'll show you 2 of those because those things are important. But when we looked at the angio follow-ups that we had were greater than 6 months, 8 of the 10 women who failed had extrinsic only stenosis. And they were the classic pseudotumor, young, obese, extrinsic stenosis only. Now I want to go over both the intrinsic and the extrinsic failures. The intrinsics were just my fault. This one you see at 60 months, she had a recurrence. What happened, this was when I was still putting in short stents. And what happened there is I barely hit this intrinsic stenosis. I think it's just a big pachyonic granulation. And over time, it eventually popped out from underneath the stent and was producing a gradient again, and she had papilledema. My partner put a stent in, and 3 years later, she's got no papilledema. This was another one. Don't make this mistake. So this is a 52-year-old, and she's got bilateral intrinsic, extrinsic. And she also has an anatomic variant with a high bifurcation of the superior sagittal sinus. So there's a vertical and horizontal part of the transverse sinus. So I put in the stent, and I got too close to the curve. And it did drop the gradient, but within 10 months, she's back with papilledema, and she's got a kink there now. And the gradient is now back up to 21. And she still has the other stenosis. So I've just converted her to two different, one stenosis is in a new area. And I thought about this, and I actually didn't want to mess with going up those vertical segments. So I put a stent on the other side, and that dropped the gradient again. And angiographically, the gradient was normal at 30 months, and at 52 months, she's free of papilledema. So those are the intrinsics. The real interesting group are the ones that get the stent-adjacent stenosis in a normal sinus. And this is what it looks like. And you've shown a couple of cases now where what happens is you get this tapered narrowing of the transverse above a short stent, and it's tightest right above the stent. And that's just extrinsic stenosis compression. And so we had this brilliant idea about 10 years ago, let's just stent the whole thing. Well, that doesn't work either, because you see there that what happens is just what you just showed here, Dr. Ramos, that now you get a posterior superior sagittal sinus stenosis, and you also tend to compress the contralateral transverse. So extended stenting. This was the first one we did in 2012. And she came in and had been referred for urgent stenting, opening pressure 55. That's an extrinsic stenosis. And so dropped the pressure gradient with a short stent, comes back 17 months later, papilledema, opening pressure 47, and she's got a tapered and a new gradient. So I fixed that with another stent just in the transverse, dropped the pressure gradient to 3, and 15 months later, she's back again, papilledema, opening pressure 51. And now she's got the posterior sagittal sinus stenosis. We explained to her, we're going to shunt her, and we explained to the shunt versus stenting, and she absolutely refused to have a shunt. She wanted another stent. We said, well, we've never done it, but let's try it. So I put in another posterior sagittal sinus stent and dropped the pressure gradient to 3, and here she is 8.5 years later with a normal gradient and no papilledema. Now, why would that work? And we think that you need to drop the pressure in the superior sagittal sinus. That's key, the whole way in the sagittal sinus. There's this obscure paper in 2008 in this journal, and these were 9 patients with pseudotumor, and they had a catheter in the lumbar CSF, so they could put in and take out CSF, and they also had a catheter in the superior sagittal sinus, so they could infuse and drain CSF and change the pressure, the CSF, and the two pressures tracked exactly as did all the waveforms and everything. So this is some evidence that superior sagittal sinus pressure is really key. Now here was a mistake I made. Did an extended stent. You can see the posterior sinus narrowing, and put a stent in, and I measured the gradient, and the gradient afterwards was 4. And notice where I measured the gradient. Well, her symptoms didn't get better, so I studied her 4 days later, and that stenosis is still as bad, if not a little worse. But this time I went up to the anterior superior, and lo and behold, the gradient is actually 20, not 4 like I thought. And when I came back along the stenosis, you see the pressure gradient dropping. And so I had measured the pressure here when I should have measured it here. That's the last time we measured pressures in the posterior. We now go up to the anterior superior sagittal sinus to measure pressures. So I thought maybe that's going to go away on its own. It didn't. Here she is 5 weeks later. It's tighter, gradient's higher. So I put in another stent. And there, the gradient dropped to 6. And 26 months later, you see the gradient is still 6, and she has no papilledema at 80 months. And then along came this patient, 20 years old, and she'd had a failed fenestration, and she's going blind. And she sent for urgent stenting. And so over 10 weeks, my partner put in 3 stents. First the transverse, and then the posterior, and then the mid-superior sagittal. Papilledema didn't change. And here she was 6 weeks later, and she still has a gradient in that anterior part of the superior sagittal sinus. And about this, and we're thinking, okay, we're going to have to shunt her. Well, she announced that she was pregnant, and our neurosurgeons didn't want to shunt her. So I told my partner, hey, look, we haven't seen any problem with the stents. Let's just go full metal jacket and do the whole thing. Well, the systems weren't long enough to get there from the groin, so he had to stick her jugular to do this. Put in a 3rd stent, and for the first time, her papilledema resolved. And here she was with a normal gradient 10 months later, and her papilledema has been resolved and still resolved at 60 months, and after a couple of kids. And that's led to this new approach on just a few cases. Here was an 18-year-old, 390 pounds, BMI of 54. And again, urgent stenting because her vision's going to hell. And so here is her study. It's an extrinsic stenosis with a 21 gradient. Now, from what I've shown you and what we knew by this time, if we put in just a transverse sinus, she's going to fail. So right from the beginning, even with that normal looking posterior sagittal sinus, I did that and went up the posterior sagittal sinus. And here she is 2 years later. I'm sorry, the gradient's there. Here's 2 years later. Still that little stenosis there, but so far that gradient has stayed the same. The last we saw her is at 27 months, and she hasn't shown up for about a year, but if her vision was going bad, we think she would. Her BMI now is 60. So with the follow-up, and this is stuff we have not published, but we have 8 patients who had superior sagittal sinus. And what's happened to them? 6 were done for hemodynamic failure and 2 for primary stenting. And all of these are patent and with a normal gradient and no papilledema. The 6 patients with follow-up, there are 2 kind of poorly compliant patients with only 2 and 13 months follow. The rest are longer term. The 2 patients with primary stenting are also longer term. So it looks like if you follow it out and finally get rid of the stenosis and get the gradient dropped, it's going to stay that way. So what we think is that if you have extrinsic only stenosis, the typical pseudotumor patient, obese, young, extrinsic stenosis, they are likely to fail. If a patient has intrinsic stenosis, they likely are not going to fail. Most males have, that's a typo, it's intrinsic stenosis, and they don't fail. Females with intrinsic stenosis won't fail. It's the extrinsics. We have very limited experience at this point with extended stenting, but it looks quite favorable. And in 2 of the 8, we've had to extend above just the posterior sagittal sinus. Okay, that's it. How do I get out of this?
Oh, I'm gonna grab the sharing.
There we go. Okay.
Yeah. Yeah, that was fascinating. We've come across that a couple of times where we see a recurrent stenosis towards like the superior sagittal sinus, and we haven't gone that far yet. But I know with the Zilver, it's definitely feasible to get the Zilver up there. So
just get the conduit catheter up to wherever the upper end of the stent's going to be. And incidentally, our indication for doing an extended stent is clinical, papilledema.
Yeah.
Yeah, we don't treat just pressures. And I did have one patient who did develop that sinus narrowing on the posterior and did have about a 15 gradient, but we followed her because she did not have papilledema. I studied her about 2 years later, and it didn't look very much different, but the gradient was 4. So we only treat when they have recurrent papilledema.
Okay.
I think
Dave,
go ahead.
No, I want to ask Dave. So these are fascinating. Thanks for sharing. Based on this, so where do you recommend that we start measuring our pressures in a routine case? Try to go all the way anterior?
Always anterior on back.
Anterior superior sagittal sinus, and then come back and do a routine.
And that's where we do our venogram. Now, when you get up there, give a little whiff of contrast to make sure you're not in the cortical vein and that you're in the main channel.
Sure.
And then when you do a venogram from there, it's useful because and the flow is fast. So you actually need to film this at 4 per second. And I use a 3 cc syringe because you need a volume in there. And you do a firm injection, filming at 4 cc's a second, and then see which side the flow goes out, because that's going to be the side that you want to stent. And along that line, with the dominant sinus, the pattern you often see is that the superior sagittal empties into this dominant, and then the straight sinus empties into the medial side of the non-dominant, and there may or may not be a connection between the left and the right. The left, where the straight sinus hits the transverse, may be away from the torcular somewhat. And so there is a variable connection in that kind of arrangement between the non-dominant and dominant sinuses, and sometimes they don't connect at all. You want to stent the dominant side because you want to decompress the superior sagittal sinus.
I think all this experience again underscores the importance of follow-up in these patients. I mean, this is a fairly newer concept of how to deal with this disorder. And, you know, when I started thinking about, okay, how about we do like a 2-year follow-up on everybody? I mean, because we need to know what happens to these patients in the long term. And we're seeing more and more things. We're seeing more of those Juxta-stent stenosis that are asymptomatic, but we have encountered 3 cases that actually needed treatment. And again, it was something that has not been described, and we needed to really think hard if we're going to extend a stent into the sagittal sinus. But knowing that you have almost no case reported in the literature or from asking other colleagues of covering the vein of Labé with the small surface area of the silver stent, I think that gave us more courage to go ahead and proceed with stenting on the superior sagittal sinus, knowing again that the chance that one of the cortical bridging veins would be compromised, that likelihood was going to be small. But I really would like to study this even further down the road. And sometimes it's difficult. These are all young people that are not in the mood of coming to the hospital and having procedures. I emphasize to them that it's going to be very important to come for at least the 2-year follow-up. And so far, they have been compliant with that. And they have been fairly compliant with the neurophthalmological follow-up. But I really would like to see how this fares even further down the road, at 5 years, at 10 years, because we need to have a better understanding. We still don't know much about what is going on. It would be also nice to have the ability to visualize and see which actually is intrinsic and which one is extrinsic. And I have entertained either ultrasound or other modalities, but I tried, and the results are not very good. They're not very useful to understand what may be going inside. So until a more direct visualization process through angioscopy or other modalities, I think that we really don't know what's going on at that corner of the transverse.
Follow-up, based on what I showed you there, what our guys are now doing is they're not doing very often venographic follow-up. As you saw, The latest failure we saw, except for that one outlier, was 24 months. And then it also turns out that what you want to treat is recurrent papilledema. And so just neuro-ophthalmologic follow-up plus OCTs is, it seems to be sufficient. And then not only, we mentioned in our 2017 paper, both the extended stenting and the follow-up at the time. This is much further follow-up, that it stayed patent. But also about the Labé, that has remained patent. There was a paper from Barrow a number of years ago also saying the same thing about Labé, that it stays patent. So I don't think that you need to worry too much about covering Labé at all. And there aren't, I would love for some other people, this is a small series where I've talked about this intrinsic versus extrinsic and who fails. And we have yet to see a single intrinsic fail. Now, I hope somebody with a larger series would go back and try to verify or prove us wrong. But it looks right now to us like those extrinsic ones are the ones who fail, and that's how you manage it.
That's a great idea. I'll get on it on our end for sure. So the next case, in-stent stenosis or thrombosis and recurrent symptoms. How do we manage those cases? So, in our case series, it's been very rare. There's been one case of like a thrombus inside a stent, and it did not result in any stenosis. And then, there's questions about management, anticoagulation or thrombectomy or angioplasty. In this case, because it was not stenotic, we elected for anticoagulation. Then the question comes up, and I'm going to show you a case where, things were managed with contralateral stenting. So this is a patient that was referred to me by a colleague who gave me permission to share this case. But it was a young lady with opening pressure of 39, headaches and papilledema. It looks like the long, maybe, extrinsic stenosis. They, got the pressure measurements, 48, 22, so big pressure gradient, went ahead and did the stent. I think it looks like here they used a Zilver as well. And then after angioplasty and stenting, the gradient dropped to 5 millimeters or centimeters of water. Yeah, the gradient dropped to 5 millimeters of mercury. Patient did well, the headaches were gone, the papilledema improved. Then the patient came back several months later with increasing headaches and vision worsening, and then had an opening pressure of 57 centimeters of water, left greater than right papilledema, got a left-sided optic nerve sheath fenestration, still had bilateral papilledema. And then we see here, the MRV, there's the loss of signal inside the stent. And this is one of the reasons why we use CT venography to follow. But if you look at this post-contrast MRI, the stent looks patent, and the stent was patent on the CT venogram as well. But then when they brought the patient to venography, the left-sided gradient looked worse. And then you can see this long kind of extrinsic stenosis along the entirety of the right transverse sinus and then transverse sigmoid junction just at where the stent was placed. So basically the patient got, recurrent extrinsic stenoses and worsening of the stenosis on the left. They did angioplasty and stenting, and then, ended up getting a good result there. And basically, the gradient improved. But then 4 weeks later, the patient had, again, worsening papilledema, higher opening pressure of 60 centimeters of water. And you can see here that there was extensive bilateral dural venous sinus thrombosis. Basically the whole venous system was rerouting and draining through the cavernous sinus and the facial veins. So that patient was started on heparin, was restarted on Diamox, basically, when they come to to me, you know, they asked about declotting the stent, and you know, I said, you know, I would just continue the anticoagulation, and I didn't think about declotting the stent because I just didn't think that was going to relieve the patient's, you know, vision-threatening papilledema. So the patient ended up getting a shunt back home, and has done okay. But, you know, she does have bilateral optic nerve sheath atrophy now with some preserved central vision. So, you know, in that case, you know, I guess the question is, you know, what would be your management strategy if you saw, you know, extensive in-stent thrombosis? Would you just opt for medical management? You know, would you consider angioplasty or repeat stenting or thrombolysis? You know, those are just some questions for Dr. Ramos, Dr. Kumpi, Dr. Lanzino. And
how long after after the thrombosis happened did you get her?
it was like 3 months. So I felt like that thrombus was going to be really chronic, and I could just
At that period, it'd be hard. Well,
yeah,
look,
yeah. So I didn't
very
want.
briefly, he stented the non-dominant sinus,
That's a
and he also just put in a short stent, and then he got a Juxta-stent stenosis above that. The pressure went back up. He put in another short stent, and I think if he had gone on the left side, the dominant sinus, and stented, like I said, in the usual fashion from most of the transverse over down the sigmoid, none of this would have happened.
Yeah, I think that's a point very important to emphasize, because you might be tempted to go by pressure gradient, and sometimes the pressure gradient might be highest on the non-dominant side. But as Dave mentioned, if you open the dominant side, we have shown that you resolve the pressure on the contralateral side. But it's very important to really start on the dominant side. And I must also like to add that the only case of thrombosis we have observed so far has been in a situation where we did the dominant side first. Patient came back with recurrent symptoms. I suspect if today, after this webinar, we would have measured the pressure all the way in the superior sagittal sinus, we would have found the gradient there. But what we did, we went on and stented the contralateral non-dominant side, and sure enough, a few weeks later, that side where there was really very slow flow anyhow became thrombosed. So I would be very, very cautious in any case to touch the non-dominant side for this disease.
Did you have something? Do you want to share anything in this case?
I think, again, it depends on the overall clot burden and the acuity of the chronicity of the thrombus. I think that within a period of a week, especially if there has been some anticoagulation, I think it would be worth exploring to try to declot stents. But again, I don't have anything else to add to your management, which was, you know, managed to bring the patient back. So whatever you do, well.
I think I would try this, that it would be best if you could reestablish patency there, obviously. And at 3 months, it's not very likely you're going to be able to, but I would at least give it a whack and go up there and just see if you could get through the clot. The chances are you're going to be running into a brick and you won't be able to get through. But if you could pass through that clot and get up into the superior sagittal sinus, and they lay stents all along that would probably stay open.
Mm-hmm.
But most likely you would fail, and I wouldn't be too aggressive about it, but I would give it a try.
Walid, before we're approaching the end, but before we conclude, if you don't mind, I'd like we have Dr. Ramos and Dr. Kumpi here, just like a few fire questions, practical questions. What is your gradient cutoff? Because we have used 10, but the truth is that if it's 8 and we think we should give it a try, we tend to give it a try. But what is your cutoff, and is there a cutoff, or each patient should be treated differently? in terms of the gradient, a minimum gradient?
Well, we use 10, but 10 is, a 10 gradient. I'd really want to see some papilledema. I said, really? There's papilledema? Usually the gradient is much higher. And then in follow-up, as I said, even though we're looking for a gradient less than 10 to call it hemodynamic success. If the gradient is 12 or something, if it went from 4 to 12, but there's no papilledema, well, that's still a clinical success. And as long as there's no visual damage and no papilledema in follow-up, we pay less attention to the gradient. And that's why I think neuro-ophthalmology follow-up and OCT measurements to see how thick, what the swelling is doing is probably sufficient.
I agree with Dr. Compe that the presence of papilledema is the strongest and solitary indication for treatment, and what determines whether retreatment is necessary as well in cases of Juxta-stent stenosis, as we saw. I personally use a cutoff of 8 millimeters, but again, looking back at the series of 75 patients, the mean gradient was 23 millimeters of mercury. I mean, those gradients are usually much higher whenever there is presence of papilledema. So I would recommend for somebody who is new into starting these procedures to make sure that their patient has papilledema, that their patient is followed up by neuro-ophthalmology at regular intervals, and to do a case, one of the first cases to do that has a gradient of at least 8 to 10 millimeters of mercury. I have put stents, I'll tell you, I have done stenting in 2 patients that I had treated for multiple sinus occlusions acutely, that they were very sick, in a coma, and I opened up those sinuses, and after a year they were complaining of headaches, and I went in and I said, okay, I'm willing to explore and see if there is any pressure gradient, or if there is any. And there was a moderate pressure gradient in one of them. Like, I think it was 6 millimeters. I still stented it, and she has actually done well. But this is an exception to the rule. So I think the presence of papilledema should be the guiding principle in treatment or retreatment for that purpose as well.
Now, the literature says that 80 to 90% of patients after venous sinus stenting at 1 year, their headaches is better. Now, my experience has been, and that's what I tell patients, I tell them, I say, look, we can control your ICP, and I know that because if we put a stent, your papilledema will improve. If you have a bruit, the bruit will respond. I'll be honest, headache for me has been a hit and miss. What's your experience?
Yeah, we when I first started looking at this, there were reports in the literature that the headache is fixed, and so I looked at our data, and after stenting, 15% had no headache, and 15% were unchanged, and the rest were improved. They were better, but they still had headaches. And I said, wait a minute, they still have headaches. Most patients still have headaches. So what I tell patients is, look, we're going to fix your papilledema. The headache, we can't fix that. It's quite variable, and because there's migraine and cluster, all these various kinds of headaches, and it may improve, and you may have less headache, but we're not going to fix your headache. And if it happens to get fixed, that's going to be a bonus. When you look at the literature on what happens when you do control the pressure in patients with IIH, Friedman had a series of that, and after good medical control of the ICP, 67% of patients still had headaches. So there's no reason to think that we'll do any better.
I totally agree, Dr. Compe. Again, I emphasize as well to my patients that we will treat and we will most likely be able to get rid of any headache that's associated with intracranial hypertension, resolve the papilledema. But obviously, I mean, this population of patients can be difficult to manage. They, as you said, they have migraines, they have tension headaches, they have generalized unhappiness in life. I mean, with patients with also this very high BMIs, there is an element of depression. There are multiple other clinical conditions that go along, and we need to be careful not to over promise, but to under promise and hopefully over deliver. But it is certainly not very likely to resolve all headaches. But I can tell you from my experience, at least, I mean, I don't remember any patient that I had shunted in the past to complain of no headache. I mean, all of them I have seen on follow-ups over and over and over. Nobody's happy. But I can reassure you that I have multiple patients in this series that are very, very happy. And, you know, I'm always taken by surprise. I see them for their 2-year follow-up. I go and talk to them before we go in. And many a times I'm taken aback by the fact that they have no complaint whatsoever. So yes, certainly there will be still unhappiness, and there will still be headache, but I think when comparing to the symptoms, the subjective symptoms in the patients who had been shunted, either lumboperitoneal or ventriculoperitoneal, I think the results are much better. Anecdotally, personal experience.
Great. Well, you know, I think we covered a lot of ground here. I know the last thing we were going to talk about was the role for bilateral stenting, but I'll just kind of tell anyone that's listening, what Stylianos and I were talking about earlier, that, we would never do bilateral stenting on the first visit for a patient. We only stent one side, the dominant sinus. And in both of our experiences, between the two of us, I think between Stylianos' experience and our experience at Mayo, less than 5% of patients end up with a stent on the contralateral side. Usually, we're more aggressive about treating an ipsilateral, Juxta-stent stenosis. But that's just something for anyone that's listening. And I'd like to thank everyone for coming, and thank especially Dr. Cumpy and Dr. Ramos and Dr. Lanzino. It's really good to hear from the experiences, and I hope that that people learn something. We're trying to talk about difficult cases. As you can see, it's not always easy, and this is great for papilledema, but this shouldn't be thought of as a cure for headache in these patients. So I don't know if anyone else has any other closing things they wanted to add.
One last thing on the stenting of the bilateral transverse sigmoid junctions. I would be, if I were to do that, I would leave at least 2 months interval in between cases, and I would tend to keep the patient on oral anticoagulation instead, because as you showed in your case, I mean, there is always a possibility. You might be thinking that these are co-dominant sinuses, but you may be wrong. One may be actually more dominant, and you need to be careful. And I would recommend the use of oral anticoagulation for that time period.
Before you even think about putting in a stent on the other side, I would get a sinus pressure measurement from the anterior superior sagittal all the way back, because you want to decrease the pressure in the superior sagittal sinus, the entire superior sagittal sinus. And if you got that fixed, then the a stent on the other side, if there's no gradient on the with the first stent on the one side, and there's no gradient between the anterior superior and the internal jugular, a contralateral stent isn't going to do anything.
Giuseppe, any closing comments?
Oh, I like to thank everybody for participating, and I think it has been very, very useful. A lot of practical points and practical input. I know that I definitely learn a lot myself. So great. Thanks, everybody.
Thank you, everybody. All right. And feel free to shoot me an email if you have any questions, and I can relay it to our team. Thanks, everyone.
Thank you, sir.